Being here. My name is Josh. Last name Lawler. Alrighty. So I'm just going to go through some housekeeping stuff first before we start the webinar. I love questions, but let's leave all questions in the chat, and we're going to do a Q&A at the end just to kind of organize our time and optimize it. And we're going to do a drawing today for a 1 free year Picmonic subscription. We just have to maintain presence throughout the webinar, and we will report who won at the end of it. And this is also going to be recorded, available on YouTube. Picmonic will send you guys a link to that video after we're done here today. So stay tuned as well, because there's a special promotion at the end of this webinar. So I just want to welcome everybody again. Hi, hello from Missouri. And I'm going to kind of just talk about myself for a moment before we go. I'm a Picmonic nursing scholar. I've been working for Picmonic for about 1.5 years. I discovered Picmonic through my wife, and she's active in social media. And she kind of heard about it and told me about it, but I put it on the back burner until about 6 months of studying in my current program, which is the nurse practitioner program at Missouri State University. And I graduate with a doctorate in nursing practice on this Friday. So I'm pretty excited about that. And I encourage every one of you to look at your careers as nurses now as steps forward, and just to enjoy as much as you can, because you never know if you're going to go back and do it again. So, I think being a nurse just in general is so fun. It's just been awesome. I've been a nurse for about 11 years. I've worked med-surg, primary care, specialty care, internal medicine, same-day surgery. I've worked in nursing management, nursing administration, and then I finally got to my favorite after about 8 years, which is the emergency room. And so I had to try everything before I found my favorite one, and ER is fun. So I have a great time with it. I'm chaotic to begin with, so that's kind of probably why I like it there. And then my favorite beverage for a warm and sunny spring day is a Boulevard Tank 7. For all you Boulevard fans out there, it's a wonderful drink. It's a beer. So I'm going to tell you about my Picmonic experience. I'm still active daily with Picmonic. I do about 40 daily review questions. I built it into my study routine and habits. It's a solid foundation for my nurse practitioner program. I started it about 2 years ago and kind of built how I usually study daily. And most recently, I reviewed the chronic myelogenous leukemia and Hodgkin's lymphoma assessment for interventions. So some pretty in-depth stuff associated with the hematologic and oncologic things that you guys have probably learned in nursing school as well, but may forget just because it's not a daily thing that we kind of deal with it, especially if you're not working in an oncology floor. And even after 2 years, I haven't reached the end of the content that's available on Picmonic. I've worked as hard as I can to try and get there. I do about 2 new videos a day for the past 2 years, maybe give or take some days off, obviously. And I don't really take advantage as much of the playlists or study session builder as much as I'd like to. And like I said, I'm a chaotic person. That's probably why I'm not as organized as somebody who may be going to the ICU or is an ICU nurse. But I function well that way. I want to go over my favorite Picmonic character, and that is the War Fairy for warfarin. She's fantastic. I think she has a pretty badass backstory that I don't know, and I wish Picmonic would release so we would know. So yeah, I think we could maybe crowdsource that maybe. Academically, I found the developmental milestones for different age groups to be the most important Picmonic related content I've seen. And it's because I don't have a background in pediatrics, though I am becoming a family nurse practitioner and I'll be working with peds a lot. Just understanding those developmental milestones from that content has allowed me to kind of see the differences that some children have whenever they arrive in the exam room. And I have children myself, so even some of the differences I see within my own children, and not necessarily measuring them in a certain way, but just seeing how people grow and seeing backgrounds. I think it's really interesting, and Picmonic has helped me kind of open my eyes to that. All right, so that's everything about me. I'm going to go ahead and get into the content. So what are the basics of electrolytes? Electrolytes, they're minerals with an electrical charge. Be found all throughout your body and in your urine, in your body tissues, and other bodily fluids, and even outside the human body. And I'm not a molecular chemist by any means, so humor me. I think electrolytes are around us all the time, in different stages. They serve many functions when they're within the body. So some of the functions are fluid and pH balances, acids and bases, movement and nutrients into your cells, metabolic wastes out of the cells, physiologic functions such as cardiac or nerve conduction. The electrolytes I'm going to cover today are the basic ones you guys have probably gone through in your nursing programs: sodium, calcium, potassium, chloride, magnesium, and phosphate. There's a few more out there. And once you kind of get into specifics, if you're working in specific nursing floors or you're working with specific doctors, they're going to be more interested in some of the other ones like copper, zinc, those sorts of things. All right, so if we're starting with sodium, the reference range I'm going to give you guys is 136 to 145 millimoles per liter. And some texts will give you different numbers and ranges. When you guys become nurses and you're working in a specific place, a laboratory is going to set your range or the range they follow. And they follow guidance generally from populations, from what current evidence says. So you may see 136, you may see 135, but the main point when you're preparing for the NCLEX is to know what, like kind of what the variation of the range is, but to know clinically what is going on with that story, what's going on with that patient in the story. What were the preceding events going into that patient's presentation? Those are the things to understand when you're understanding the stem of an NCLEX question, and to understand what does that actually mean. It's not necessarily memorizing those numbers, it's understanding what's happening with the patient, because that's what you're going to have to do whenever you're working, is you're going to see that number, and then you're going to look at your patient and you're going to say, what is that? Why is this number and why is this happening here? And that's where that understanding comes from. So the first thing I'm going to go into is hyponatremia. So what does it look like? Signs and symptoms are weakness, fatigue, confusion, muscle twitching, seizures, and a decreased level of consciousness. It can be caused by diarrhea, vomiting, kidney disease, Addison disease, cirrhosis, malnutrition, heart failure, and water intoxication. Also, if sodium is collecting intracellularly with resulting fluid volume expansion within the cell, that can lead to low serum sodium levels or low extracellular sodium levels, because the sodium is not where it's supposed to be. Sodium likes to be outside the cell. That's how it functions with that sodium potassium pump. And if it's not outside the cell, then you're not going to see it whenever you take a blood draw, because we don't really measure what's within the cell per se. There's ways of doing that, but we don't do it on a basics level. So how do you treat hyponatremia? You treat it with hypertonic solutions, like 3 to 5% sodium chloride. And that's generally for patients presenting with low serum sodium and low fluid. So you're kind of replacing the sodium and the fluid. If a patient also is having fluid restriction, such as they're having water intoxication where they're diluting their sodium, that would be a case for hypertonic solutions. An example of a disease process is psychogenic polydipsia, is when a patient kind of compulsively drinks water, and can't stop. And then also mannitol we use. Sometimes I think they're looking more at doing hypertonic solutions for increased intracranial pressure. And if you guys gone through your critical care rotations, then you know better than I on that. Hypernatremia, so what is that? It's excessive thirst, infrequent urination, vomiting, diarrhea, dry flesh skin, orthostatic hypotension, and changes to your level of consciousness. We kind of saw that some of those were similar to what hyponatremia is. And like I said, read the question thoroughly, read the stem of the question thoroughly to know what that clinical presentation is. So when you have hypernatremia, it could be caused by diarrhea, it could be caused by dehydration, adrenal gland dysfunction, kidney disease or disorder, and diabetes insipidus. Okay, and it's treated by preventing dehydration. Prevention is the best cure. Restricting sodium intake and using hypotonic fluids, 0.225% to 0.45% sodium chloride, very diluted types of solutions, as opposed to what hypernatremic or hypertonic fluids are. And that's in the presence of a patient with a fluid deficit, where you're correcting the fluid deficit and you're correcting the hypernatremia. Next, we're going to go into calcium. So calcium loves protein and it needs it to hitch a ride around the body. So whenever you want to see true calcium levels, you have to see the unbound version of it, also known as the ionized calcium levels, in order to see what a true calcium level is. And we do that a lot if a protein is scarce to begin with, such as in liver disease. The protein's not being made, the albumin's not being synthesized by the liver, so it's not available for the calcium to hitch right. So we want to see a true calcium level. It's going to be the free ionized calcium. Reference range for calcium, this is for bound and unbound, is 8.5 to 10.2 milligrams per deciliter. I'm going to start with hypocalcemia, so low calcium. What you're going to see is muscle spasms, and think of calcium as a neuromuscular sedative, decreased bone density, tetany, so using those signs, the Czosek and the Trosu signs. You're going to see increased deep tendon reflexes. You'll see ECG changes, a QT prolongation, and increased cardiac cell excitability and seizures. Whenever you have hypocalcemia, it's going to be caused sometimes by malabsorption in the intestines. Calcium's not being absorbed. Hypoparathyroidism. So remember, parathyroid loves calcium, but it hates phosphate. So if you can guys remember that, hates phosphate, loves calcium. Kidney failure can cause hypocalcemia, hypoalbuminemia, which is that low albumin level, sepsis, hypomagnesemia, and vitamin D deficiency and alkalosis. You treat hypocalcemia by treating the underlying condition and supplementing oral IV calcium. In an acute setting, you can do the IV calcium, but you want to be able to monitor at the same time cardiac, respiratory status. Because if you overcorrect, you can send them into something worse than what they began with. Next, I'm going to go into hypercalcemia, or high calcium levels. So think too much sedative. You're going to see lethargy with the patient, pathologic fractures, because the calcium's not where it's supposed to be. It's not in the bones. It's in the serum. It's in the blood. So those pathologic fractures can point to hypercalcemia. Sometimes you may see it with oncological patients, cancer patients, if they have that issue. Hypercoagulation, so think that calcium's in the bloodstream, so it can cause some problems that way. Constipation and QT shortening on the ECG. There's an acronym called 2 chimpanzees. The T in 2 stands for thyroid disorders causing hypercalcemia. And then the chimpanzees acronym is excess calcium supplements, hyperparathyroidism, iatrogenic, meaning you don't know why hypercalcemia is, or maybe you don't know yet why hypercalcemia is there. Milk alkali syndrome, Paget's disease, adrenal insufficiency, neoplasm, Zollinger-Ellison syndrome, and excess vitamin A. The main point to learning that acronym is to know that there are specific diseases that can contribute to hypercalcemia. You don't really have to necessarily know the specifics of those diseases for the NCLEX. You just have to kind of be familiar, and you have to be maybe familiar with the disease processes as to why, but it doesn't really have to do with memorizing an acronym like that, okay? It's about using the acronym for your advantage whenever you're trying to answer the question. Oh, I'm sorry, excess vitamin A and excess vitamin D and sarcoidosis. That was the end of the acronym. I had to scroll down on my notes here. It's treated for hypercalcemia by limiting your calcium intake, chelation, or you're binding the calcium using certain drugs, such as calcitonin, biphosphonates. And if you DC thiazide diuretics and you add loop diuretics, that can help to correct hypercalcemia. You also want to increase the fluids to dilute the levels. All right, potassium is next. It assists with nerve, cardiac, and muscular functions, as well as bringing nutrients to the cell and escorting waste byproducts out. The range is 3.5 to 5 milliequivalents per liter. And hypocalcemia, or low potassium, you're going to see muscle weakness, arrhythmias, or a U wave on the ECG. A U wave is kind of going down, so think of that as hypo, low. Ileus and hyporeflexia. It's caused by that insufficient dietary intake of potassium. It can be caused by alcoholism, diarrhea, vomiting, and diuretics, or the acronym DVD, diarrhea, vomiting, and diuretics, and aldosteronism, too much aldosterone in the bloodstream. Thiazide and loop diuretics can also cause a loss of potassium in the urine. Laxatives, vomiting, diarrhea lead to loss in the stool or malabsorption of potassium in the stool. And insulin or alkalotic conditions will lock potassium in its home, which is within the cell. So if there's too much of that going on, the sodium potassium pump doesn't function regularly as it should. It's treated by infusing a potassium at 5 to 10 milliequivalents per hour if you're doing an IV infusion. And then if you're doing oral potassium, it's just based on how profound that hypocalcemia is. Whenever you're doing an IV infusion, like I said, with the IV infusion of calcium, you want to monitor that cardiac and respiratory status. Just because those changes can happen pretty fast, and it's for the patient's safety, really. Hyperkalemia, high potassium, signs, symptoms, abdominal cramps, muscle weakness, diarrhea, and arrhythmias. Tall peaked T waves, so as opposed to the U wave, low hypokalemia, tall peaked T waves for hyperkalemia. It's caused by chronic kidney disease, burns or trauma, Addison's disease, diabetes type 1. Medications can cause it, like some antibiotics, and excessive dietary intake. With trauma or burns, what happens is that the cells are bursting and the intracellular potassium is being released into the serum extracellularly. And that's why you see that hyperkalemia. Potassium sparing diuretics, because potassium is not being excreted, or it's not in the urine, it's being retained. And then Addison's disease is that aldosterone deficiency. So with an aldosterone deficiency, aldosterone likes sodium and water. And if there's not enough aldosterone, then there's not that exchange in the renal tubules for the sodium and water or the potassium. So the potassium is also being retained in that case as well. It's just a dysfunction. You treat hyperkalemia by using diuretics. So those potassium wasting, like the thiazides, K-exolate for binding in the abdomen or in the intestines, or use a combination of glucose and insulin so that you are unlocking the cell and the sodium potassium pump can function regularly. And then educating on proper intake of potassium if a patient is taking too much dietary. And that's generally with patients with kidney disease, they have that problem a lot of times. Next is chloride, and chloride is useful for neuronal activity. The range is 95 to 105 milliequivalents per liter. Hypocalcemia, or the low, signs and symptoms is fatigue, weakness, respiratory distress, numbness and tingling, and confusion. Can be caused by lung disease, heart failure, Addison's, metabolic alkalosis. It often corresponds with hyponatremia, sodium chloride, they're buddies. And it's treated by replacing sodium chloride a lot of times. And you're also treating that underlying condition that's causing the low chloride levels. Hyperchloremia, the high chloride levels, similar presentation to hypochloremia, and you add vomiting, diarrhea, and dehydration. So that DVD as well you may see hyperchloremia associated with those symptoms. It can be caused by that dehydration from those, or kidney disease, or acidosis, or alkalosis. And you want to treat the underlying acidosis and alkalosis to treat the hyperchloremia as well as treating any underlying conditions that's causing it. The next electrolyte's magnesium. It's useful for cardiac, neuronal, muscular function, and has over 300 biochemical reactions in the body. The reference range is 1.5 to 2.5 milliequivalents per liter, and it's found intracellularly, acting closely with calcium and potassium. Hypomagnesemia, signs and symptoms: confusion, increased deep tendon reflexes, insomnia, tachycardia, seizures, muscle cramps, tremors. And I'm just going to make a quick mention that you can see those signs and symptoms. They kind of go together a little bit. A lot of hyperactivity going on whenever you have low magnesium levels. So if you guys have kind of a hard time remembering some of those specific signs and symptoms, kind of remember that a low magnesium level may correspond with some of the other low electrolytes or high electrolytes in those cases. It may help you with the stem of the question as well if it's something that's a little confusing. So hypomagnesemia caused by diarrhea, vomiting, chronic malabsorption. If you're doing nasogastric suctioning, anytime that you're kind of taking away the absorption of dietary magnesium, you may cause hypomagnesemia. You can treat it with oral magnesium for mild cases and IV magnesium for severe cases. But like I said before, you want to monitor cardiac and respiratory. And with this sort of replacement IV magnesium, you want to administer it very slowly to decrease the risk of cardiac events. Hypermagnesemia, signs and symptoms: flushing, lethargy, muscle weakness, decreased deep tendon reflexes, hypopnea, bradycardia, and hypotension. It's caused by the excessive administration of magnesium sulfate, particularly with patients who are pregnant and they're managing eclampsia with magnesium sulfate. And also for kidney disease and insufficiency when they're unable to properly manage magnesium levels in their bloodstream or in their urine. You can treat it by dialysis with kidney disease, IV calcium gluconate or opposing magnesium neuromuscular effects, using diuretics, avoiding antacids that have magnesium or laxatives that have that in there, and decreasing that dietary intake of magnesium. The last electrolyte I'm going to go through is phosphate. So phosphate's found in bones, teeth. It works with calcium to fortify those things. It supports transportation of adenosine triphosphate, or ATP, which is useful in garnering energy for cells. Reference range for phosphate is 2.5 to 4.5. Hypophosphatemia, the signs and symptoms are fatigue, muscle cramps, bone pain, calcification of soft tissues, organs, reduced ability to use iron, calcium, magnesium, and zinc. Caused by the inadequate intake of phosphorus, or it can be caused by alcoholism, which generally interferes with a lot of electrolyte intake or absorption. Hyperparathyroidism, so remember that parathyroid hates the phosphate, loves the calcium. And osteomalacia, or that's also known as a vitamin D deficiency, causing bone softening. Treatment is correcting the underlying condition and replacing the phosphorus orally. Last is hyperphosphatemia, and the signs and symptoms are very similar to hypophosphatemia. It's kind of hard to distinguish between those two. So once again, fatigue, muscle cramps, bone pain, those sorts of things. It can be caused by kidney disease, hypoparathyroidism, low parathyroid, too much vitamin D, diabetic ketoacidosis, or excessive phosphate in the diet. And for correcting hyperphosphatemia, you want to treat the underlying condition and you want to reduce dietary intake of phosphate and absorption of that. So that concludes the content portion of this. I will take questions now. It's 2:25. So I will wait. I will have questions here in a moment, if you guys have any. Okay. So the first question I have is, any tips on how to incorporate kinesthetic learning style with Picmonic? So I think by kinesthetic, I'm thinking so we're talking about like visual, auditory, kinesthetic being kind of movement based, not really necessarily movement based, but more active sort of participation and learning style. I'm going to answer this the best I can. And I don't know if it's going to answer your question at all, but I'll try. So with kinesthetic, a lot of times I think with Picmonic, if I am learning a particular thing, tactile, yes, okay, tactile. If I'm learning a particular thing, what's really important is the clinical environment. If you're a portion of that, that's where your lab is a lot of times. So remembering, maybe you're not in clinic now because you're preparing for the NCLEX, but remembering those times when you tactically solve this. So whenever you view a Picmonic and you're starting to review a concept or you're learning a new concept, remembering a specific reflecting event that you had that you can use your senses for, and that may help create a picture in your mind, and that may help kind of correspond the information you're seeing right then in a kinesthetic way or in a tactile way. I would say that's probably one of the best ways to do it. There's probably other ways to do it that I don't know. But that would be my advice for that question. All right, so I'll take another question. I hope that answered what you had, or at least gave a little bit of insight on that. Can you please describe and name the hand movements when taking a blood pressure if a patient has hypocalcemia? So we're talking about the Phosphate and Trosu signs, so mainly Trosu's on that one. So Trosu, if you're taking a blood pressure, and generally, now forgive me, I didn't review as much as into Trosu as I should have on this. I do know that there's a lot of cramping involved with the hand movements whenever you have that. And I think with a blood pressure, whenever you're having that pressure kind of build up on that upper arm, once you get to a certain millimeter of mercury of pressure, you're going to see it probably slowly move into that. If it's a profound hypocalcemia, it may be a little bit quicker. Generally, what you're seeing whenever you see those low calcium levels, I think I had some notes on this. Give me one quick second. All right, I think I might have reviewed it, but anyways, so what you're seeing whenever you have neuromuscular action potential, I don't know if you guys went through this in nursing school. And if you go through your advanced nursing school later on, your APRN, you may go more into this, but action potentials a lot of times. Calcium is kind of useful for the prolongation of electrical signal. So if you have a low calcium level, then it's not going to be as prolonged. It's going to be quick in how it moves. So most likely, whenever you see a Trosu sign, you're going to see that the blood pressure start to build pressure, and you may see a quick movement of that hand into a cramp. And generally, it's just kind of like a flexion of the hand, inflecting the wrist, flexion of the wrist, flexion of the fingers. Kind of a neuromuscular response without having cognitive control over that, just because the electrolytes that are available. All right, let's see if there's any more questions. No additional questions. Fantastic. Okay, so I want to announce the winner of the 1 free year of Picmonic, and the winner is Evan Hill. So let's give him a hearty round of applause. Fantastic. Hope you love it and use it. Keep it around if you go to your second, if you go to your advanced program later on. And with no further questions, let me look at my notes here. I want to thank everybody once again for being here. I really enjoyed. This is my first time to ever kind of give a webinar, so I hope I did okay for you guys, and I really wish you guys luck on the NCLEX. I'll be there with you taking my board certification here next couple of weeks for a nurse practitioner. And so we're all in the same boat on this, and I think we're always going to be in the same boat, regardless. So the recording will be available tomorrow morning on YouTube. We'll email you that link, like I said. And the promotion for today is 30% off when you subscribe to Picmonic in the next 24 hours. There's 2 ways to get this. Click the link in the chat right now to purchase if you guys have been wanting to purchase to get that 30% off, or you can wait an hour and receive the email with the link directly to the discounted pricing. So once again, I want to thank everybody. I want to wish you guys luck on the NCLEX. I want to see you all on the front lines of nursing. I look forward to it. Hopefully I get to see you again in the future in person. I'd really, really enjoy that. And so this is the end. Have a great day.